So I'm going to talk to you about some common things in head and neck imaging. But here we go. If you just want to have that kind of like the view from 30,000 feet, what imaging test do you choose? This is kind of the way I look at it. I am unashamedly a CT fan. CT is very often diagnostic for a lot of head and neck pathology. It directs therapy immediately. Patients are going to go to the OR. Very often that's the information they need. That's enough to get you there. So I like CT, but certainly I do a lot of MR, read a lot of MR, and I think MR has incredible utility. In problem cases where there are very specific and directed questions, and classically orbital or intracranial disease as an extension of head and neck tumors and head and neck infectious disease, MR clearly has a leg up. Ultrasound, we don't do near as much ultrasound as the Europeans do, but I think ultrasound is vastly underutilized. And the evaluation of local disease, patients, the first topic we're going to talk about, just a neck mass, we don't do enough, and it's a very good study. Interestingly enough, I've had this discussion with a lot of people over the years. My training program, our residency program, is now buying our new residents a handheld ultrasound device. And it's theirs. And they use it. They walk around, when they go, we have a resident that's always assigned to rounds with a clinical team, and they cart their little ultrasound device around with them. And I'm sure they ultrasound their friends and, their pets or whatever at home too. But the widespread applicability of ultrasound and the widespread use of ultrasound is something we all have to acknowledge now. Everybody's got one. All my ENT surgeons carry one in their pocket. They're everywhere. We don't do enough ultrasound. We've kind of allowed that to kind of slip away from us, and I think that's unfortunate. So here's some common presentations that we're going to discuss. A neck mass in an adult, puffy, bulging, or red eye, red throat, red neck, ear pain. So let's begin with a neck mass. Neck mass in adult patients. So a patient in their 40s, 50s, typically the setting is like someone's either putting on their makeup or shaving in the morning, and they notice they have a little bump on their neck, and they feel it, and there's something there. Occasionally, they are first discovered by their family physician. So a neck mass in an adult patient, how should it be addressed? I think, we all went to medical school or the radiology tech. There are a few techs in the audience, I understand. We all kind of understand how we should deal with something. We want to question it and get our fingers on it and kind of what is it? So the history and physical examination is very important. And particularly with head and neck disease, a careful attention to people who have smoked and drank a lot. That's very important. ENT surgeons are invariably going to scope people. They have those flexible scopes. They're very easy to utilize. So a direct visualization of every visible mucosal surface is pretty much a part of their examination. But then we have the next part of the list, and that's ultrasound plus or minus needle aspiration, antibiotics, follow-up, and imaging. And the order of those items and how you apply them is really the whole key. And if there's a little artistry here, that's where the artistry is applied.
So I'm going to leave the brain and go out a little bit laterally to look at the cerebellopontine angle and the IAC in our next lecture. So I have nothing to disclose. I don't own the CP angle. I don't make money if you look at the CP angle or anything else. So just like everything else, we're going to look at the anatomy here. Just like everything else kind of in the head and neck world, I really think the cranial nerves and the skull base should be in head and neck, not in general brain, guys. But we're going to look at the anatomy, what normally lives at this location, and then look at the pathology that happens to the anatomy and see how we can differentiate it. So we're going to start off with the anatomy at this location, the CP angle and the IAC. So the very complex kind of anatomy around this area where we think about the cerebellopontine angle and the internal auditory canal with these nerves 7 and 8 going through that area and the anatomy around it. So we have the restiform body or the inferior cerebellar peduncle that we have right here. Then we have the flocculus, kind of tuft of wool, a highly vascularized part that we think about at the cerebellum there, and a little bit of choroid that's coming out laterally from the fourth ventricle. And then we have those nerves 7 and 8 that are going over to the cochlea of the vestibule, and then the seventh nerve with its tortuous course to the temporal bone. So when we think about pathology that happens in this area, this is a very confusing little part. Like a lot of head and neck, there's a lot of little parts in this area. But if we think about what anatomy is normally at this location and what pathology happens to that anatomy and how those look on imaging, we can sometimes differentiate exactly what it is. Just like the jugular foramen, if we often have a well-done CT and an MRI, we can sometimes tell you exactly what the pathology is before we go to a biopsy. That's a very powerful thing to always be able to do at that location. So that's the anatomy that we have around there. Restiform body, the flocculus, a little bit of choroid, 7 and 8, and then the CSF, the peel and dural surfaces that you already heard about, are kind of around that area. So that's the anatomy at this location. So we have the facial nerve, the cochlear nerve, and the superior and the inferior vestibular nerve. So we have 4 nerves that are going through the IAC. Out laterally, we have some parts. We used to think about the lateral aspect of the interlaudatory canal as the macula cribosa. It's kind of Swiss cheese. There were all these holes, and the nerves just kind of divided and went through there. But when we image these cases now on well-done thin section CT, you can actually see these little tiny channels, and this is very exciting for us. So we've got a horizontal or vertical crest or Bill's bar in the crista falciformis out laterally, where we think about 7 and 8 in the superior and the inferior vestibular nerve that are going over towards the cochlea, the vestibule, and the facial nerve with its tortuous course through the temporal bone that we'll talk about more tomorrow.
So I'm going to talk about post-treatment imaging. I'm not going to talk so much about tumor response and efficacy. That's a pretty big topic in itself, but it's a little bit murkier. Head and neck post-treatment imaging is probably the toughest thing that I do, and it's the easiest to commit errors. It's extremely humbling. There is no substitute for experience. I understand that many of you may not be seeing a lot of these kinds of cases depending on what your practice is like, but inevitably you will be seeing some of it. And I think you have to make mistakes. Climbing a learning curve just means making mistakes, right? Isn't that what that means? So much of where I am is because of sort of hard lessons in this kind of imaging. So because we see so many cancers and we have a huge plastic surgery service and a very big head and neck surgery service, we're doing a lot of really tough cases, especially the skull base and sinonasal cases. So post-treatment complications are, it's easy to know that something is wrong, figuring out exactly what it is, differentiating post-treatment change, expected post-treatment change versus complications of therapy or even tumor recurrence or a combination thereof is extremely difficult, and that there's many potholes sort of to fall into. I'll start with a few of the post-surgical complications, some of the more common ones, and I'll spend most of the rest of the time talking about radiation complications. So, after surgery, you can get any type of infection. You can get cellulitis, you can get an abscess, and differentiating from fluid collections, non-infected fluid collections, can be difficult. Patients may have intentional or unintentional denervation patterns. You can get various seals, that is, obstructive fluid collections of various types, and I'll show some of these as well as a few omas, fistulas, leaks, and breakdowns. So I'll show some of these things, and then I'll talk about radiation for the rest of the time. So here's a patient who had a neck dissection, and we can see that the right hemi-tongue is both T2 hyperintense and enhances, completely respecting the midline. Now, I have seen enhancement in a denervated tongue called tumor. Not often, but certainly if it respects the midline like this, that is a classic appearance of subacute denervation. That is before the tongue becomes fatty infiltrated. And notice also that the back of that denervated tongue kind of protrudes into the oropharynx and is posterior to the back of the left side of the tongue. That elongation of the tongue is another classic sign of acute/subacute denervation. And if you dig into the op note in this case, you could read that they had to sacrifice the hypoglossal nerve. So you're lucky if you can find that kind of verbiage in an op note. And op notes can be very sort of tedious to go through because we're not surgeons. We don't necessarily follow everything they've done, but you often find pearls that will help you in those reports.